Okay, welcome everybody, and thank you so much for attending this webinar on Ask the Expert about dystonia and botulinum toxin. We have four panelists here tonight, but mainly you'll be speaking with, sorry, you won't be speaking with, but you'll be listening to Dr. Thomas, who is, and now I have to look at a piece of paper because he has a very long list of qualifications and responsibilities. Dr. Thomas is a UK consultant in both neurorehabilitation and stroke medicine, and he works across two sites in the northeast of England, which is where I live. He leads 3 to 4 specialist botulinum toxin clinics each week and focuses on the management of generalised and focal dystonia. He is particularly interested in complex dystonia management through multidisciplinary rehabilitation, and he regularly manages complex dystonia cases referred from across the region. He's also the Assistant Medical Director for Neurological and Specialist Services and is the Training Programme Director for Rehabilitation Medicine in the northeast of England. And he is a Fellow of the Royal College of Physicians and is currently undertaking a funded MBA in Leadership and Management. So I think he's very highly qualified to answer all of your questions. And we also have Jukka Sillanpaa. Jukka is a friend and colleague from Dystonia Europe, and he will be answering questions tonight from the patient's perspective. And we have Edwige Ponsil from also a friend and colleague from Dystonia Europe, and
Hello.
She's looking after the technical side. And I'm Jill Ainsley, and I'm currently the acting president for Dystonia Europe, and I'll be asking the questions. Okay, so during the webinar, you feel free to put questions in the question and answer function at the bottom of the screen. We do have a very long list of questions, and we know we'll not get through them all tonight. So any questions previously submitted that we don't answer, and any questions that you put in the question and answer box will be answered after the webinar, and they'll be published underneath the video, in the comments underneath the video on our YouTube channel. And so I will hand over to Dr. Thomas, who's going to give us a short presentation.
Well, thank you very much, Jill, and the team for inviting me. It's an absolute pleasure and an honor to speak to all of you. I wish we could do this in person, but I believe Teams or Zoom is equally good, and I'm hoping I can answer as many questions as I can. What I'm going to do now is I'm going to share my screen, and then I will start. There you go. Could you confirm that you can see my slide?
Yes, it's okay. Thanks.
Brilliant. Excellent. So as Jill has highlighted, I am a consultant. I work at a place called Newcastle upon Tyne in the northeast of England in a center named Walkley Park. It's our regional neurorehabilitation and neuropsychiatry center. So we are a level 1. That's the top hierarchy in terms of neurorehabilitation inpatient care for the region that covers the whole of the north of England. We also look after complex toxin-related work that includes spasticity, dystonia, hypersalivation, hyperhidrosis, and to be honest, most things that deal with toxin we are able to do, unless it's specifically intraorganal toxin-related work. Now, the topic that was assigned to me was to talk about dystonia and botulism and our botulinum toxin injections. And what I thought I'll do is I'll quickly run through what is dystonia, which I'm sure most of you know, and you'd all be very much experts in this area. And then I'll go on to what botulinum toxin is, what it's used for, its pathophysiology, its side effects, and when it's really effective and what we can do in toxin failure cases. So as I'm sure most of you know, dystonia is a neurological disorder causing involuntary muscle contraction, quite often a problem in the way the brain controls muscle. Though a lot of people still don't know exactly what causes it, but it does result in abnormal posturing, pain, tremors, twisting, and jerky movements, just to name a few. And as I said, no one's sure exactly what's causing it, and we suspect it may be related to an area in the brain called the basal ganglia, which is responsible for putting brakes on movement. And when those brakes are released or not working, it allows the body to go into a hyperkinetic state or increased movement. Sometimes it may be related to genetic factors. Sometimes it may be related to certain enzymes or hormones in the body, particularly dopamine. It may be related to repetitive movement, as in musicians' dystonia or some sort of physiological conditions. It may occur after trauma or injury, and sometimes even with the use of medications. Now, as I'm sure you all know, dystonia is not one particular topic. It can encompass a wide range of movement problems all across the body. Some people present with a twisted neck, others with eye closure. Some people may have hand cramps or finger problems, some with toes or feet problem or gait issues, and some with jaw movement, facial problems, or affecting the whole body or half of the body. So it is very much unique, and so the treatment around dystonia has to be very much individualized. The symptoms that dystonia can cause, apart from involuntary muscle contraction, can also lead to pain, tremors, speech difficulty, swallowing problems, and not to mention postural abnormalities or gait issues. There are different ways in which you can classify dystonia, but the most simplest and easiest way is to think about whether dystonia is affecting one single area of the body, or whether it's affecting one or two areas, or whether it's affecting a large proportion of the body. And that's where we have this classification of focal dystonia. And again, you can talk about dystonia affecting the eyes, as in blepharospasm, or the oromandibular area, the jaw and the tongue. It could be the fingers or the arms, as in writer's cramp or arm dystonia. It could be the neck, causing cervical dystonia, like torticollis. It could affect just the trunk alone or just the feet. And when two or three of these areas are affected side by side, we often call it segmental dystonia. Or when a large proportion of the body is affected, we call it generalized dystonia. There are other classification methodologies like primary and secondary, or age related, or underlying pathophysiology, but quite often thinking of it as focal, segmental, and generalized does help, especially in terms of treatment. And coming on to treatment, the first line often botulism toxin, or Botox, or Xeomin, or Allergan, depending on what's available in the country that you're in. It's an injection that is done on a regular basis every 3 to 4 months, and I'll come on to why we do that every 3 to 4 months. You could consider medications like oral muscle relaxants or anticholinergics, example trihexyphenidyl, though some of them do have side effects which prevent the use of higher doses. You could consider adjuvants, or things that you can do along with toxin and medications, like physiotherapy, and some even talk about acupuncture or heat therapy or aromatherapy, though them alone does not help. There are advances in the treatment of dystonia, namely deep brain stimulators, transcranial brain stimulators, better targeting of injections, and even genetic tests, but these are all still in the experimental stage. Now, coming on to the topic that's assigned, and I'm going to be talking on botulinum toxin in dystonia. The picture that you have here are three of the most common brands that are used in dystonia, namely Dysport, Xeomin, and Botox. They have been around for quite a while, and the earliest use of toxin in any muscle-related activity was back in the 1970s and the 1980s. There was an ophthalmologist in the US who had extracted botulism, or botulinum toxin, from the bacteria Clostridium botulini, which often led to people having botulism or a complete paralysis of the body. What this physician was able to do was extract the toxin and attach it to a protein. Think of it as a person who could be dangerous, but if you place them in a car or a box, they are less dangerous, and that box or the car is used as transport. So when this person started injecting muscles, they found that those muscles get paralyzed without the generalized problem of botulism. They started experimenting this on animals, and later started injecting children with squints or eye problems. And they found that by injecting the eye muscles which are causing squint, it corrects it, and children are able to see better without the need for surgery. However, most of these injections only lasted for a short period of time, and so they had to be repeated on a regular basis. It was Botox, or the company that owned Botox or runs it at the moment, that discovered this, and they started marketing it and called it Botox back in the 1980s and 1990s. And that's why everyone knows about Botox. It's because they were first off the line to say. When they started injecting patients for squints and other conditions, they found that a lot of women and men didn't have as many wrinkles on their forehead. And that's when they applied for cosmetic licensing for the use of botulinum toxin. And that's the whole marketing behind Botox and cosmetic use. Other companies like MERS developed Xeomin, and Dysport or Ipsen developed Dysport. There are a few other companies as well, but essentially they are all using the same idea, as in extracting botulinum toxin type A, attaching it to a certain protein, making it safe to allow it to be injected. Each of these companies have toxin that paralyze the muscle, and they develop units to allow people to quantify how much toxin needs to be used to paralyze a muscle. Dysport units are different from Xeomin's units, which again is different from Botox's units. So they're not completely interchangeable or exchangeable, though we do have some strategies on how to equate them. They all have different ways and mechanisms in which they are stored, and that can differentiate them. For example, Xeomin may not need a significant or strict cold storage regime, whereas Dysport and Botox might do so. Though again, they are working on different strategies to allow it to be used outside a cold storage chain. How it works is it stops the passage or the transmission of nerve fibers or connections. Essentially, your brain tells your muscles what to do, and it does so by nerve connections in a way from your brain all the way to your muscles through your spinal cord. Now, when the muscle is injected with botulinum toxin, you have a protein or a toxin that goes and attaches to certain vesicles that prevents the release of certain enzymes, and it's the prevention of release of these enzymes that does not allow nerve conduction to happen. So it, in a sense, paralyzes the muscle and prevents the muscle from contracting or acting. Now, after a while, the nerve forms new connections and it resprouts those areas. And so the effect of the toxin wears off. And that's why, after around 3 to sometimes even 6 months, the toxin completely dissipates and you have to re inject the person. If we were to then target muscles which are overactive, as in the case of dystonia, we could correct the overactivity and allow the person to regain some function or position depending on which muscle was injected. Now, if you can think about the common types of dystonia, for example, cervical, MAGE, writer's cramp, foot dystonia, and once you realize which muscles might be involved, then you can target those muscles to try and reduce the overactivity of that muscle and help correct or rectify or reduce the symptoms of dystonia. So quite often, botulinum toxin techniques rely on pattern recognition and anatomical localization. So once you recognize a pattern and you know the muscles that are causing it, then you could inject it. Quite often, we can use guided injection techniques with the use of EMG or electromyography, nerve stimulation, ultrasound, and in less common cases, a CT scan or an MRI scan. I usually start quite low when I start off injecting a patient for dystonia, and I increase the dose in the second, third, or fourth cycle, and each cycle is around 3 months long. And the reason I do this is to ensure that the patient does not suffer any side effects, and then they can build up the dose depending on how the effects are. Theoretically, the effects of toxin occurs within 12 to 24 hours, though observed effects usually occur only after 4 to 14 days. And the effects last for around 3 to 4 months in general, though in some cases it may last longer, and in some cases shorter as well. Injecting a patient before the 3-month mark risks the development of antibodies or the body's own immune reaction towards these toxins, which theoretically could decrease the effectiveness of future treatment. The one thing that I always think about and I talk to the patient about in terms of botulinum toxin is it is used to weaken a muscle. So it does not give you any extra strength. It does not improve function on itself unless you're sure about what it would do. So botulinum toxin does not improve underlying weakness. Therefore, if dystonia or spasticity or muscle tightness is being used as a substitute for strength, injections may make the situation worse. They do have side effects. Toxin, as with any injection, can cause bleeding, bruising, scarring at the site of injection. In some cases, it may cause a flu-like illness in the first few weeks, which usually subsides. Sometimes the toxin may be over-effective, causing excessive weakness, or it might be under-effective. And sometimes the toxin may dissipate or spread to nearby muscles, causing weakness. And this can be particularly troublesome in areas around the neck, which are close to your breathing and swallowing apparatus, and that may, in rare cases, cause respiratory or swallowing problems. And again, once you counsel the patient, talk about it, and start off low, then we can try and reduce these kind of risks or use guided techniques. Now, that is a business stop tour about botulinum toxin in dystonia. I'm opening the floor to questions.
Thank you, Dr. Thomas. That was really interesting. And even though I've had dystonia for 20 years and I've been to many presentations, I still learned there were some things in there that I didn't know about. Thank you for that. Right, we'll start with the questions. And the first one is for you, Dr. Thomas, is how do you deal with SCM atrophy after many years of botulinum toxin injections? And I think, well, I'm not sure what SCM means, so if you could explain what that is as well. Thank you.
Lovely, thank you. And it's a very good question. SCM, I believe the person's asking about is a sternocleidomastoid. It's a very interesting muscle that starts from your skull in your mastoid process or this bony prominence just behind your ear and goes and attaches to your clavicle or collarbone as well as your sternal bone. And that's where it gets its name, sternocleidomastoid. Now, the two muscles on either side are very good in terms of rotating your head as well as flexing your head or tilting your head back and flexing your neck. We often inject that muscle in torticollis or cervical dystonia, and because it's a very common muscle to be injected, and if it gets injected for a long period of time, as in the person's case, it may lead to atrophy or thinning, and that's true for any muscle, and that is a problem or a risk with toxin. Now, the management includes adjusting the dose of toxin, and you may need to think about whether we should or shouldn't inject it and whether we can inject other muscles. We may have to have a period of toxin holiday if it is a severe atrophy. And by that, I mean not injecting for 1 or 2 cycles to allow the muscle to come back or regain some strength, and using adjuvants like physiotherapy to strengthen surrounding muscles.
Thank you. I'm sure that was answered very fully. Thank you, Dr. Thomas. The next one is from a gentleman who says his wife was diagnosed at 41 and she had difficulty being diagnosed until she got to see the correct neurologist. And he would like to know how to prevent the achingly slow process of diagnosis. And I think across all of Europe, we can all agree that sometimes it is far too slow to get that diagnosis. So how could we prevent that?
What this person is describing isn't uncommon. And as you say, it is unfortunately still the reality even in 2026. And the only way we can improve it is by doing the work that you're doing, Dystonia Europe, Jill, your team, essentially increasing the awareness, educating people, not just the general population, but also clinicians and specialists. Even in the world of neurology, quite often it can be a challenge. I'm not a neurologist, I'm a rehabilitation or a physiatrist or a specialist in rehabilitation medicine. And even in our field, it can be quite challenging. And so, quite often, you might have to have specialists who deal with movement disorders, neurology, and that could be neurologists, geriatricians, internists who specialize in movement disorders that might pick it up. So, an early referral to a movement disorder specialist or clinic and improved education around general neurology and general neurologists, as well as the general population, would be key in speeding this up.
Thank you. Yes, that is something that Dystonia Europe works very hard on. We do a lot of awareness raising amongst medical professions. Thank you. I think we move to Jukka. Jukka, can you take a question?
Yes.
Hi, Jukka. Someone asks, what is the best way for you to cope with your dystonia?
Well, I think that it's very important you to avoid just identifying you a person living with dystonia. It doesn't define you, and I want to be very open with this disease, not to fundamentally refuse to do something because I have dystonia. I'm open to tell, okay, I suffer from it, but I don't. It doesn't affect too much my life. It's an attitude thing, but unfortunately, I was able to receive a diagnosis, or I was diagnosed very early stage of my disease. So I'm in a very pretty, relatively pretty condition. But it's a very mental thing. Of course, your family, your friends must support you, etc. But be active. Don't let the dystonia win you. Just go ahead. Be positive. Be open.
That's great advice, Jukka. I think we have dystonia, but we are not dystonia. Yeah. Thank you, Jukka. And back to Dr. Thomas. How long would the botulinum toxin stay in your system? Actually, I think you've already covered that one, haven't you? Yeah, it's 3 to 4 months. We'll move on to the next question. Is Botox, well, botulinum toxin, whichever brand it is it useful for oromandibular dystonia?
Yes, it can be quite effective in oromandibular dystonia. It may take a few trials or cycles before we can get to their exact muscles, and so it does require a bit of patience, but it is very effective.
That's good, thank you. And which type of toxin is the best one?
To be honest, there is no best choice, and it really depends on individual response. Some people may respond better to one rather than the other. There is trials and work looking at whether one might last longer than the other, or one might be less immunogenic, which by that I mean it produces less antibodies, but it would really be just individual response.
Yes, I kind of thought that. I think I've had all of the variants over the years. And one more for you, and then we'll go back to Jukka. Is there a possibility to heal or cure dystonia in the future?
So there is currently no cure, but treatment can significantly improve symptoms. Research is going into genetics and brain-based therapies, and I'm hoping that in future we may be able to find a cure.
Yes, I think we're all hoping for that. That would be wonderful. Jukka, can you take another question?
Yes, please.
Do you have any special strategies to cope with your dystonia?
Yes, maybe it was something what I just mentioned. In a social circumstances, I don't try to hide my disease because you can see it from my gestures and in my movements. But I also tell that my illness is not infectious. So if I sneeze or touch or whatever, don't be afraid of me. So it's very important just to tell that I'm a normal person. Don't worry about that. There's nothing to be afraid of. That's very important, so that you can have that social life, live like a normal person. I think that's the main issue to cope with dystonia.
Yeah, I totally agree, Jukka. Live like a normal person. Thank you, Jukka. Dr. Thomas, this is a similar question to the first one, but it's slightly different. It's what are the unwelcome effects of long-term toxin injections? Could it cause scar tissue?
So long-term use of botulinum toxin is generally regarded as safe, but you are right, there are possible effects, particularly because we are weakening a muscle. And when a muscle doesn't get strength, it will shrink or atrophy or thin, and this can lead to posture problems, contractures, or the loss of the function that you were originally injecting the person for. Now, significant scar tissue is not typical unless you are injecting a site or a particular site quite commonly, or you cause a lot of hematoma bruising on a recurrent basis. So it would be rare, but cannot be completely ruled out.
That's good, thank you. Should guided injections be the standard?
Now, by guided injection, just to clarify, I suspect the person who's asking the question is asking about ultrasound or electromyography or certain types of tests that you can localize the muscle. And I certainly do it in my clinic. I find it easy. I've trained with it. However, it isn't a must. And the reason is we are all trained to do it anatomically, and the muscles, fortunately, haven't changed for centuries, and they all remain the same. And so anatomical is perfectly fine. However, ultrasound does improve accuracy because you can see exactly where the toxin is going, exactly where your needle is, and no one can refute that. Now, it might not always be possible, especially in hyperkinetic or excessive movement dystonia, where you're trying to hold a probe and do the injection. It might actually be potentially even dangerous in those situations. So I usually say it's individualized. It does improve accuracy. If it can be done, it should be done. If it isn't done, it doesn't mean that the person is getting less good care or less beneficial care, but it would just need to be individualized for that person.
That's good to know, but it's kind of the story of dystonia, isn't it? That we're all different. Yeah. Are there any general physio or exercise resources for individuals to use at home?
So in our center, we do have physiotherapists who are involved in the dystonia service. It's a multidisciplinary service. We also have physiotherapists who are injectors in the United Kingdom. With regards to pure physiotherapy, gentle stretching, postural work, sensory techniques can help. A neurophysiotherapist is usually a better person to provide a tailored guidance around this rather than a general physiotherapist, quite often because of the nature of their work and their expertise. However, I use it as an adjunct or an adjunct to treatment rather than treatment on its own, because quite often, once that input is stopped, the person will have the dystonic symptoms again.
Yes, I do some physio myself, and it does help temporarily. And on the Dystonia Europe website, we have a link to a physio hub on which patients can use the physio finder to find a suitably trained physio near where they live. And we share that information regularly on our Facebook page. Edvish might be able to put a link in the chat box, but have a look at our website and look for the physio hub. Okay, I think Jukka, it's back to you now. Have you felt your dystonia has changed over the years, Jukka?
Yes, I think that in the beginning it started very strongly. My head was turning remarkably to the left, and I had a lot of pain. But as I said, luckily I was able to get diagnosis very early. So I guess that the treatment has had better effects. And nowadays, I think I'm quite stable with that. I get still treatments, but I don't have that kind of pain, or anxiety, and my head is in a better status of my neck at the moment. So it can vary, but it starts, then you get treatment. It is good or bad. I had a good treatment. Now I'm in a better situation. So there is help.
Thank you, Jukka. That's good to know. Okay, back to Dr. Thomas. There's one of the questions is asking about the amounts of toxin, and this person, his or her toxin, is the dosage is getting higher and higher, and they're worried about how it can actually go. And would it be advisable to have DBS instead? And this person is 65.
Now, there technically is no fixed maximum dose. However, there are licensed maximum dose from each of the brands. So Zoomin might say for the sternocleidomastoid, as in the muscle we spoke about before, the maximum licensed dose, and I'm just saying it might not be, but it might be 100 units. Whereas for Dysport, it might be 300 or 400 units. And so they have certain licensed dosing regimes based on their own research and what has been approved in your own country. Saying that, having an off-licensed increased dose can be done as long as it is discussed by the clinician and the patient and is agreed why you're doing it, how it's going to affect, and the risks involved. Rising doses in itself shouldn't be worrying, but as we increase the dose, it does increase the risk of side effects, particularly around atrophy, thinning, weakness, spread of toxin. And so you always have to balance whether you're doing the right thing. And this is where using additional techniques like ultrasound or EMG may help, because then you can be sure you're actually injecting the correct muscle rather than just injecting in an area and hoping that it goes to the right area. Now, in our center or in Newcastle, we do have a DBS facility in our tertiary regional hospital, and we can refer patients across. An age itself isn't a cutoff, though certainly as we get older, our comorbidities increase, which may put people off the chance of having DBS. But it is definitely something to consider, and as with everything, it has to be individualized.
Yeah, and definitely something to discuss with your doctor. And this is a slightly different question. What is the average dose of toxin for treating musicians' focal dystonia?
And again, this is a nice, interesting question, because you would think that musicians' focal dystonia or hand dystonia or so on would have a very set regime, but actually it doesn't. There is no standard dose because it depends on how the dystonia is affecting the person. If it causes your fingers to move, then you may have to target a certain dose to those fingers, depending on which finger is involved. I quite often start low and then work my way up. Now, short duration or limited effects may indicate that you need to adjust the dose and you might have to increase the dose. And it's finding that balance between over weakness and control of dystonia. We have an idea of what we start with, but it wouldn't be termed as a standard.
Okay, again, it's like all of us, we're all so different. It must be very difficult to come up with a common treatment strategy.
It is pattern recognition, and to be honest, I find it an art form, and that's why I love dystonia and I love my work in toxin. Because when a person comes in and you see their smile or you see their neck and you want to adjust it, it's like a painter going and painting or trying to correct it, working with the patient to create that right regime. And in some patients, they may not want it fully corrected. They might want certain symptoms corrected, like the tremor or pain, and the posture might not be as much of a problem. So I find it's like art.
That's a lovely way to look at it. Yeah. Okay, in photophobia-driven blepharospasm, what is your strategy when effective treatment of the medial upper eyelid leads to dose-limiting side effects?
So in these cases, you may have to think about spreading the toxin around rather than just that particular area. Essentially, blepharospasms, you're talking about spasms around the eye muscles. And quite often, it's a muscle called your orbicularis oculi. However, it is a very thin, flat, but largely spaced out muscle. It's got different parts. It's got the ring around your eye, it's got the part that's over your eyelid, and so you could target different parts of the same muscle. You could target muscles that are nearby, for example, your forehead, just around your eyebrow, or just underneath your cheekbone, which may have an effect or an adjunct to this. And sometimes you may have to consider a higher concentration of toxin rather than the standard regime to try and reduce the risk of spread of toxin.
That is interesting. Thank you. Okay, back to Jukka. Can we ask you another question? Jukka? Excuse me.
Yes, please.
Yeah. Are you satisfied with the treatment that you get?
Actually, yes, quite satisfied. I get botulinum toxin injections, and the intervals have been quite standard. There was a period when the interval was varied from 3, 4, 5 months, and during that time it was a little bit painful. I noticed that that period is too long, but recently the intervals have been 3 months, and I'm very satisfied with that. And I have even been able to choose from those between those different toxins, and they have been agreed with my neurologist that Botox works for me. And additionally, I get 15 times a year of 15 appointments with my physiotherapists, and they have different kind of exercises, and he gives me some massage to neck blade area in my back, and even some massage to my neck, and it seems to work actually. So I'm satisfied. But I think that you have to be active, and because those appointments are very short. Recently, it can vary from 5 to 10 minutes with my neurologist. So be prepared to ask the questions, because the appointment is very rapidly over.
Yeah, that is really good advice, Jukka. I would advise anybody, even if you need to write down your questions and take them in with you. Yeah, that is really good. And I'm pleased to hear that the physiotherapy is working alongside your injections. That's good. So I think we've got so many questions. I think we probably need to go back to Dr. Thomas. Okay, this person has been having Botox or Dysport injections for 20 years and seems to have built up immunity just recently. They switched from Botox type A to Dysport a few years ago. Do you think switching back to Botox would work?
It would depend on whether they're still getting the effects from Dysport or not. So technically, they are all botulinum toxin type A. So the same type of toxin. It is the protein or that vehicle, as I said before, that's what keeps the toxin safe. And that's what differentiates Botox from Xeomin, from Allergan, or Dysport. Now, there are research that's done by individual companies that say one is slightly better than the other in terms of reduced antibody resistance. It still requires larger randomized controlled trials or larger studies to really effectively say that for sure. But at the moment, the strategy in our center is if you do develop a resistance to one particular brand of toxin, we often switch to another one until that stops working or the person develops resistance. And then we switch to another brand of toxin and we might cycle back again. Or we might think about a toxin holiday where we don't inject, usually for 3 to 12 months, to allow a full washout of the toxin from the body. In the past, we used to use toxin B. That's a different type of toxin. However, due to manufacturing issues, we haven't had that for a few years now.
Yeah, I'd heard that myself, that the toxin B wasn't so readily available. I think you may have already answered this. How is botulinum toxin used to treat blepharospasm?
Yes, in
Yeah,
a similar
yeah,
manner, just injections around the eyes.
yeah. And sorry, I'm just reading the questions, and some of them are repeated from what we've already covered. So this question is someone who has spastic dysphonia, and they've had botulinum toxin they had botulinum toxin over 20 years ago and had little improvement, and since then have not had any injections. They decided to just live with it. They have weekly meetings with the speech therapist, and so they ask, do you know of other people that live without botulinum toxin that have dystonia?
Absolutely. And some people can manage without injections because it is very much an individualized process. Some people find injections helpful, some people don't. Some people find the prospect of visiting a person 3 or 4 times a year quite daunting. So it really depends. In our center, because we cover such a large area, I do have patients who live 40, 50, 60 miles away, and they find making the trip every 3 to 4 months challenging, and they've decided to live with it, which is unfortunate because we aren't able to provide that care closer to home. And there are some patients who live just down the street and they decided they don't want the injections because they find injections quite troublesome or painful, and their symptoms aren't troublesome enough for them, and that is a personalized thing. Having that kind of peer support and specialist therapy does help for people to cope with it.
Yeah, I think if you can cope without the injections, then there's nothing wrong with that. Jukka, question for you. How many injections did you have? I think they mean how many times did you visit your neurologist and be injected before you felt a really good effect?
Yes, I think it's a kind of adventure because every person, every patient is different, and the method is trial and error and experimenting. And I think that neurologists, at least in Finland, they start with a very conservative dosage. And in the first appointment, I get, I think, 100 units of Botox, and it was gradually increased, I think, at least to 175, and they tried different muscles, etc. And to get the kind of balance, I think it took some 5, 6, 7 injections, so maybe 1 to 2 years it took to get the right balance. That was a kind of experimental way to find that.
I think
And
that's
now I get quite the same kind of injection schema or methodology.
yeah. I
And it
think
seems to work.
that's something we hear again and again, isn't it, from dystonia patients, that it can take a year, maybe even 2 years to get the
You can't
dosage
say
correct.
at the early stage that botulinum toxin doesn't work for me.
No, no, you have to give your medical professional time to get the
Yes.
dose right and the location right too. Okay, back to you, Dr. Thomas. Is there a link between dystonia and Parkinson's?
So the short answer is they are two distinct conditions, but they can overlap. So dystonia can occur in Parkinson's or as a treatment side effect from drugs from Parkinson's, but generally they are two separate conditions.
Okay, I must admit I know two people with Parkinson's who also have dystonia, but I didn't really understand why.
It's like having stroke and dystonia.
Yeah.
Two separate conditions, but
Yeah.
dystonia can occur in patients with strokes or head injuries, but essentially they are two separate conditions.
Yeah. I think just for myself, I think I would just be really annoyed if I got another condition. I think I've got enough. Okay, so is the botulinum toxin effective, in treating the involvement of muscles of the fingers of both hands? This person has osteoarthritis deformities in their fingers, and they'd like to know if botulinum toxin can still be effective.
And just to clarify, does this person have dystonia? The question.
Let me read the question again. I'll read the question word for word. Is botulinum toxin effective in treating the involvement of the muscles of the fingers of both hands when, due to a genetic mutation, dystonia has continued to progress to produce osteoarticular deformities?
Right. So the injections can help reduce muscle overactivity, but it cannot reverse fixed joint deformities that's already happened. And that's why early treatment is more effective. But once those deformities have occurred, it can weaken the muscle, but it won't change the joint position.
Okay, thank you. Probably not the question that person wanted, but it's an honest answer. Why does the medical world not give much focus to neuroplasticity and the ability to improve holistically, given so many people are improving and recovering this way?
It's a good question, and there is active research in this area, but the results vary, and that is the honest answer. At the moment, I suspect the best approach is for clinicians to support a combination of medical and rehabilitation approaches to allow that brain remodeling and neuroplasticity to occur. It would also depend on the underlying condition causing the dystonia, whether it's neurodegenerative versus a specific brain insult that might lend itself to neuroplasticity.
All right, thank you for that. And Jukka, I think you might have already answered this, Jukka. It says, did you see a physiotherapist, and if yes, did it help?
Yeah, I think it helps because you need strengthening of your other muscles. It's a kind of, you are an entity and you have to be treated holistically. And the physiotherapist, I have more time, it's 45 minutes appointments. So they have more to talk about health and good exercise, etc. It's a very, and the system where my physiotherapist is able to see what the neurologist has written, etc. So it's a kind of multidisciplinary way of working. And the timing of my physiotherapy is linked with my neurologist appointments with injections. Yes, and as I told, I have those 15 times appointments a year in public sector, which means it's a little bit more advantage for me in way of regarding cost to me.
Yeah, do you have to travel a long way to get your treatment, Jukka?
Actually, if I think I'm working and it's only 2 blocks away to go to physiotherapist, and it's a 3 or 4 kilometers to the hospital to meet the neurologist. So it's in the same town or city.
I think
I'm lucky, but I know that there are very long distances throughout Europe, in Finland, in Sweden, even in
There
UK.
are, yeah, even in the UK, Dr. Thomas has already mentioned that, yeah. And some, I think, I'm not sure if Catalina is online, but at one point in Romania, there was no clinics in Romania at all. So that those patients had to travel a very long way.
Yeah, and it depends on the system in each country. Sometimes it can be dispersed, and somewhere it can be very centralized, and
Yeah,
it's very much depending on that.
absolutely.
Luckily, I have a central university hospital very close to me, so I get all the treatment I need.
Yeah, you are lucky in that. Dr. Thomas, is there a short-acting way to create a test Botox? As my axial dystonia, it's not me obviously, my axial dystonia has responded wildly different, causing a lot of pain.
Now, at the moment, there is no commercially viable short-acting versions. There has been talk about a certain toxin E or other types of toxins of Clostridium botulinum, which may last for 3 to 4 weeks, and the possible clinical uses of those, for example, in scar tissue or in the condition of this person. However, commercially, it is not available, so at the moment, no would be the answer.
No. Okay. Do you know, we're getting through these questions much quicker than I thought, although we've got the 5 minutes left, I think. Okay. This person says they have blepharospasm and no toxin has worked for them in 10 years. They just had deep brain stimulation surgery. Is this the only solution for blepharospasm?
Not necessarily. So again, you could look at other types of toxins for blepharospasm. You may look at adjuvant therapy, so looking at dark glasses or shades or certain occupational therapy devices that might apply pressure to the skull and seeing if they work. And in some cases, DBS or a surgical procedure may be the only route. So it would again be individualized for the person.
Yeah. Can long-term use of the toxin permanently damage a muscle for musicians' dystonia?
Again, it comes back to the same point that permanent damage is unlikely, but repeated injections can, in some cases, cause lasting weakness, which, in a person who's using very fine, dexterous musical skills, may affect their skills.
Yeah, I've heard, I don't know any musicians personally who have that type of dystonia, but I have heard a few stories about them where it really affects their playing abilities. This question is someone who says they suffer significant incapacitating pain from their toxin injections in their neck, and it takes 3 to 4 weeks for the person to recover. They've been told by several neurologists that this shouldn't happen, but it does every time, and they'd like to know why.
So this isn't typical with botulinum toxin injections, but it can occur. And quite often, in my experience, it does happen when I might have injected the wrong muscle or muscles that are having a compensatory or a beneficial effect are accidentally injected or the toxin spreads to it. And thereby, the body doesn't know how to react. And it responds by pain because other muscles that weren't originally involved start to contract to keep the body erect or keep the neck moving and so on. And these kind of situations, that's when I usually rely on targeted approaches. I may, in those situations, try and vary the concentration of toxin, either making it very concentrated or very dilute to see if that makes a difference. I have experienced this in toxin type B, which at the moment it isn't commercially available very frequently, and that does cause pain. But a toxin type A, it is less so. Rarely, and some of my colleagues have done off license treatment where they have injected an anesthetic as well as the toxin together. However, that isn't usually recommended unless the person is an experienced clinician or is able to do that in their center.
Okay, thank you. I think you've given that person some questions that they can take to their neurologist the next time they go. This person asks, what can go wrong? I think from the sounds of it, this person hasn't seen a neurologist as yet, and they've asked how they get injections. Their GP has said that they don't do them, but do they need a neurologist referral?
So, in people who haven't been formally diagnosed, I would strongly recommend that they go and see a specialist neurologist or a specialist in movement disorders. Even a general neurologist sometimes may struggle, but most neurologists should be able to diagnose dystonia. And they might be right. Most primary care practitioners or practitioners where they don't often deal with dystonia may not have the expertise to deal with toxin. And that's why you really need to be seen by a movement disorder specialist. And in terms of what could go wrong, to be honest, very little and possibly a lot. But in the hands of an expert, the chances of side effects or risks are quite low. But that's where you have that individual discussion to make sure you are aware of what you're getting into.
So they definitely need to ask for a referral. And the last question I have here, and we've just got time to ask it, is this person has had cervical dystonia for over 35 years, and they seem to be getting sensitive to the injections as they've been having swallowing issues. The neurologist has cut their dosage down, but then the tremors are very bad. And the person asks, is this due to my age? And they're in their 70s.
So this may happen over time, and that's where dose adjustment, technical changes, or concentration changes may need to be thought about. Symptoms should be reviewed rather than dismissed, obviously, which I suspect this person's already done. And they shouldn't just be assumed as age related, which may be the case. If you're in doubt, and again, in extreme cases, you could do a toxin holiday where you don't get injected. Obviously, your tremors would get worse, but if your swallowing is equally worse, then you may have an answer to whether this is toxin related or not.
Yeah, again, really good advice. And we are spot on 6 o'clock. And Dr. Thomas, you've answered every question that we had sent in. There are some questions in the question and answer function, but we'll ask you about those afterwards. And Jukka, you answered all of the questions sent in for patients too. So I'd like to thank everyone very much for attending. I hope you've all learned what you were hoping to learn about. And a big thank you to Jukka for his taking part in answering his questions, and a really big thank you to Dr. Thomas for giving up his time and answering the questions so well. Thank you.
Thank you very much. Thank you for having me.
Thank you.
Thank
Bye-bye.
you. Bye-bye, everybody.
Bye-bye.
Bye-bye.